everyone, Dr. Campbell here, and today we're going to focus on the anesthesia section. So the anesthesia section begins on page 59 in our CPT manual, and as usual, it's important for us to note the table of contents. The anesthesia section is very, very small, guys, and it is divided in codes that start with the head and then ends with other procedures. One of the things that I think is very important to note is that when you're locating anesthesia codes in the alphabetical index, it's critical that you start with the main term of anesthesia. Reason being, if you start with any other term other than anesthesia, you may arrive at a code that is not an anesthesia code. Anesthesia codes do begin with codes 00100 all the way over to 0199. So let's talk a little bit about our anesthesia guidelines. So the first thing that is important to note is that the reporting of anesthesia services is appropriate by or under the responsible supervision of a physician. These services may include, but are not limited to, general, regional, and supplemental local anesthesia, or any other supportive care that is needed to afford the patient any type of anesthetic that is deemed necessary during a procedure. The codes in this particular area do include the usual preoperative and postoperative visits. If you've ever had surgery before under the care of an anesthesiologist, you know that the anesthesiologist comes by to let you know what's going to happen and ask you a few questions. So it does include the preoperative visits. It includes the postoperative visits. It also includes the anesthesia care during the procedure, making sure that you remain comfortable, as well as the administration of any fluids and or blood and the usual monitoring services. Now, something that is important to note, there are situations where the patient needs to have unusual forms of monitoring. Those unusual forms of monitoring, such as intra-arterial, central venous, and Swan-Ganz, are actually not included in the CPT anesthesia sections. Now, I'll tell you personally, for these particular services, intra-arterial, central venous, and Swan-Ganz catheterization, I actually have those codes listed in my CPT book on page 60, just to remind myself that these are the codes that I would use if unusual forms of monitoring are provided during a particular anesthesia service. Also on page 60, we have our guidelines for reporting of time. Per guidelines, the anesthesia time does begin when the provider is preparing the patient for their procedure. This can occur either in an operating room or other similar area. Of note, the time that's spent reviewing medical records before the surgery is not a billable service. This is actually a part of what's known as the pre-op evaluation, and it's calculated in the units that are allocated for an anesthesia service. Per guidelines, anesthesia time does end whenever the provider is no longer personally attending to the patient, as well as when the patient is safely placed into post-op anesthetic supervision. Of note, and this is not in your CPT manual, this is just kind of a FYI, some payers do report anesthesia time differently. So for payers that follow CPT rules, they actually report the time in 15-minute intervals, and in order to get to the 15-minute interval or the beginning, at least 7.5 minutes must pass in order to report a unit. So for example, let's say that the patient was, or the anesthesiologist was providing the services for 30 minutes. Well, once you get past 8 minutes, that's in your route to 15 minutes, that's 1 unit. And then when you get to the next 15 minutes, that is your second unit. On national exams, it's important for you to know CPT rules for calculating and reporting anesthesia time, as it really does vary based upon the payer itself. All right, also for anesthesia services, we have anesthesia modifiers, starting with the physical status modifiers that are found on page 61. So the physical status modifiers identify the patient's physical status at the time of the procedure. Remember, we are coding here for the anesthesiologist or the anesthesia provider, which can also, guys, be a certified registered nurse anesthetist, also known as a CRNA. So these modifiers identify the physical status. They're divided starting with P1, which is a normal healthy patient, and they can go all the way up to P6, which is a patient that's brain dead, whose organs are being removed for donor purposes. In a fair amount of organizations, it is the anesthesia provider that identifies the patient's physical status, and that's the reason why they do that preoperative interview, so that they can determine and confirm what the patient's physical status is. Now, there are also other modifiers that are utilized for anesthesia services. Those are HCPCS modifiers. I highly recommend that you write these modifiers in your CPT manual on the bottom of page 61. And these modifiers are found in your HCPCS manual, but these modifiers identify who actually provided the anesthesia service today. So for example, modifier AA is anesthesia services performed by an anesthesiologist, whereas modifier QZ, for example, is a CRNA service without direction by a physician. So again, highly recommend that you write these in your CPT manual on page 61, because if you're taking a national exam and you need to know these, this is a perfect place in the anesthesia section. Of note, when we're reporting these modifiers, we report these modifiers before we report our physical status modifiers. Why? These modifiers impact payment, and as you should know, modifiers that impact reimbursement should always be listed first. Also on page 61, we have our add-on codes that are known as qualifying circumstances. Of note, a patient has to qualify for these circumstances. These circumstances include extreme age, a patient that is under 1/70. Of note, some CPT codes do include the age as it relates to anesthesia services. You want to watch out for your parenthetical notes, because they will tell you if this add-on code should not be reported with that particular anesthesia code. Then we have 99116, which is anesthesia that's complicated by utilization of total body hypothermia. We have 99135, anesthesia complicated by utilization of controlled hypotension. And then we have 99140, which is anesthesia complicated by emergency conditions. Of note, these are add-on codes, so you know that they cannot be used alone. CPT does define an emergency condition as a situation when a delay in treatment of the patient would lead to a significant increase in the threat to life or a body part. Now, I thought it was worth noting how those codes would be used on a claim form, and this is a very small snippet of the professional fee services claim form, the CMS 1500, and I want you to notice how on the first line item we have, and I'm going to put a circle around it, we have 00 210 with the modifier AA. So here is our anesthesia code, and we know that AA means that this anesthesia service was reported directly by the anesthesiologist. But then we have our add-on code on the second line item, 99140. This lets us know that this was a emergency situation. All right, guys, other than that, I already explained to you that when you're locating these codes, you do want to start in the alphabetical index under the main term of anesthesia. That is very, very important because if you don't use the main term anesthesia, you're going to come up with the surgery code. And then other than that, guys, very small section, because the intent of this section is not to capture a surgical procedure. Rather, it is used to report the deep anesthesia services that are being provided by the anesthesia provider. Guys, thank you so much for listening and have a great day.